Good morning, dear chairs, dear audience. Welcome to my progress report. I'm Boglárka Fehér, and my topic is altered vaginal flora in pregnancy. I'm a medical doctor at the Department of Obstetrics and Gynecology at Semmelweis University, and I believe that pregnant women will have better outcomes due to professional prenatal care, and I would like to find new possibilities of screening and treatment of genital mycoplasmas during pregnancy. To complete this mission, currently I'm working on two projects which are closely related to each other. I would like to conduct them both through systematic reviews and meta-analysis. First, let me talk about my first project, which is investigating the effect of genital mycoplasmas on adverse pregnancy outcomes. The so-called genital mycoplasmas can be a part of the normal vaginal flora. Here you can see the prevalence of Ureaplasma urolithicum, Ureaplasma parvum, and Mycoplasma hominis is quite high. Mycoplasma genitalium is the only one recognized as an STI with lower prevalences. This is similar in pregnant and non-pregnant women. Unfortunately, evidence-based guidelines currently have no recommendations on genital mycoplasmas except for Mycoplasma genitalium. The reason of that is the controversial data in the literature about pathogenicity. Nevertheless, there are plenty of outcomes they can be associated with during pregnancy. First of all, in case of colonization, almost half of the pregnancies can end up preterm. Furthermore, the risk of spontaneous abortion, premature rupture of the membranes, low birth weight, and perinatal death could be unacceptably high. Although all these complications are very dreadful for pregnant women, early detection could be able to prevent them. So my aim is to investigate interrelations between genital mycoplasmas and adverse pregnancy outcomes. To reach this aim, I chose this clinical question. Do genital mycoplasmas increase the risk for adverse pregnancy outcomes? I'm going to investigate pregnant women. The exposure is genital mycoplasmas, the comparator is no genital mycoplasmas, and the outcomes are different adverse pregnancy outcomes. I hypothesize that pregnant women affected by genital mycoplasmas have higher risk for adverse pregnancy outcomes than women without genital mycoplasma infection. I've conducted a systematic search in 3 medical databases, and I've ended up with more than 10,000 findings using the search key below. After the duplicate removal and the selection of the articles, I was left with around 1,000 eligible full texts. As we have a large number of articles, we have just finished the data checking, so I'm going to present preliminary results about our primary outcome, preterm birth. Our figures show the association between the exposure of genital mycoplasmas and preterm birth, which means giving birth before the 37th week of the gestation, the complete lung maturation. We chose this as our primary outcome because of its clinical importance, being the leading cause of infant mortality and morbidity worldwide. 101 observational studies were selected for analysis, covering about 51,000 patients. We have performed a subgroup analysis of the 4 different species of genital mycoplasmas. In the first figure, you can see the subgroup analysis of Mycoplasma genitalium. Here, we could find a statistically non-significant association, but it showed to be a risk factor rather than a protective one. For Mycoplasma hominis, we could find an odds ratio of 1.84, indicating that pregnant women infected with Mycoplasma hominis have 84% increased chance to experience preterm birth compared to women without genital mycoplasma infection. According to the p-value, which was below 0.05, the results were statistically significant with moderate heterogeneity. Here you can see the subgroup analysis of the 2 different species of Ureaplasmas, Ureaplasma urolithicum and Ureaplasma parvum. Here we could find a statistically non-significant association. However, in the subgroup analysis of Ureaplasma genus, including Ureaplasma urolithicum, Ureaplasma parvum, or both, an odds ratio of 1.73 was found. This indicates that pregnant women infected with any Ureaplasma species have 73% higher risk for preterm birth compared to those without genital mycoplasma infections. The results were statistically significant with considerable heterogeneity. The potential source of heterogeneity could be the different study designs, as well as the varying sampling sites and the use of distinct diagnostic methods with different sensitivity. I would like to highlight the strengths of our study, which are the large number of articles. The articles were available for 6 outcomes of interest, and there's a possibility to perform several subgroup analyses. However, I also have to highlight the limitations, which are the high heterogeneity and the presence of potential confounding factors like the co-infections and the antibiotic treatment, and we mostly could include observational studies and only one RCT. Here you can see the current progress of our project. We are now at the stage of risk of bias assessment and waiting for further results. Up to 80% of pregnant women are affected by genital mycoplasma infection, which can significantly impact pregnancy outcomes. Clarifying the controversial data in the literature about pathogenicity is crucial during pregnancy. Our study suggests that Mycoplasma hominis and ureaplasma infections are associated with preterm birth. Consequently, routine screening should be incorporated into practice during pregnancy. Moreover, policymakers should ensure the inclusion of genital mycoplasma screening within prenatal care guidelines. However, to confirm causality, there is a stringent need for new studies based on molecular diagnostic techniques and randomized treatment protocols with promising and safe antimicrobials. Briefly, let me introduce my second project, which is investigating the effect of genital mycoplasmas on adverse outcomes in pregnancies at risk for preterm birth. Preterm birth affects 11% of pregnancies worldwide and remains the leading cause of death in children under the age of 5. Numerous risk factors contribute to preterm birth. Among obstetrics conditions, preterm labor, which means regular contractions leading to cervical change before the 37th week, poses 50% risk for preterm birth. Preterm premature rupture of the membranes occurs when membranes rupture before the onset of labor, before the 37th week, results in preterm birth in half of the cases within 1 week. Women with short cervical length faces up to 50% risk for preterm birth. Infections contribute to the half of preterm birth cases, with genital mycoplasmas being a key factor. Administration of prophylactic antibiotics have not effectively reduced global preterm birth rates, highlighting the need for further research into the relation between genital mycoplasmas and adverse outcomes in these high-risk groups. Understanding these mechanisms could improve screening and treatment strategies, as well as neonatal health outcomes. This leads me to my aim, which is to investigate interrelations between genital mycoplasmas and adverse outcomes in pregnancies at risk for preterm birth. In order to achieve this aim, I asked, do genital mycoplasmas increase the risk of adverse outcomes in high-risk pregnancies? The population is pregnant women with preterm labor, preterm premature rupture of the membranes, and cervical insufficiency. The exposure is genital mycoplasmas, the comparator is no genital mycoplasmas, and the outcomes are interval to delivery, preterm birth, perinatal death, and chorioamnionitis. I hypothesized that pregnant women at risk for preterm birth affected by genital mycoplasmas as well have shorter interval to delivery, higher risk for preterm birth, perinatal death, and chorioamnionitis than women without genital mycoplasma infections. I hope that our findings would support practitioners in providing optimal management for high-risk individuals and utilizing effective antibiotic therapy to prolong the pregnancy. We used the same search key and the same database as we did in our first project, restricted to our high-risk groups, and we are going to submit Prosper soon. To summarize, here you can see my future plans. I would like to finish both of my projects this year. Let me finish my presentation with a thought-provoking quotation by Mahatma Gandhi: "Be the change that you wish to see in the world." Thank you for your attention.
So, my name is Petrana, I am SMS here, and congratulations first of all for your speech. I would have 2 questions. The first one, if there is any preclinical study that you know of which will support the result of your first project. And the second one, as it is unethical to infect patients randomly for mycoplasma, can you tell me more about this RCT that you included? Thank you.
Yes, of course. Thank you for your questions. So first of all, there's no existing meta-analysis based on RCTs because these RCTs are kind of very old, and the data could not be assessed. There are 4 RCTs about erythromycin treatment in this pregnant woman. Erythromycin is a safe microbial in pregnancy, so it's an FDA B drug. So it could be used, but there are some problems with this treatment, so that's why I think that one of these RCTs have very large sample size, and although it could not find any significant effect. So the problem with erythromycin is that the resistance of uroplasma is increasing, although it's around 10% for now. But we have to know that mycoplasma hominis is 100% resistant to erythromycin. So maybe that's the problem with that. And the other factor is the placental passage. So there's also a limited number of studies about the passage of macrolides, but there is one, and it showed that erythromycin and azithromycin have only 3% placental passage, which is very, very low. So maybe that's why they could not show a significant effect. The other studies, there is one about azithromycin, there is one about genital, which could be effective, but the sample size was very low. So actually, it's impossible to make another meta-analysis about this topic for now. So that's why there's a need for new RCTs. And these women were not infected with mycoplasma, so they had the infection when they were randomized, because that was an inclusion criteria.
Okay, thank you.
Thank you.
Thank you for your presentation. I have a question regarding your first project. What I find also very interesting about the population history. Are those patients, is this the first pregnancy for them, or did they have preterm pregnancy before the age of the population? So can you tell us more about that? Thank you.
So we have collected all this data about these patients, but we would like to perform other subgroup analysis, as they could be potential confounding factors. We could not assess the data about the history of recurrent preterm birth and spontaneous abortion, because it was not actually linked to the exposure. It was just a characteristic table, and mostly in the studies, it was not the population was not divided as positive and negative women, but where the outcome was there and where the outcome was not. For example, preterm and term. So that's why we could not assess these data about these characteristics, but it would work.
Thank you.
Thank you very much. I'm Mikol Bakoly. I'm a statistician. Actually, I'm Bogi statistician. We've talked so much, but just one question came to my mind. I'm already over family planning, but there are many young women around here. So what would you say? Should they immediately rush to some private clinic and screen themselves, regardless of not having any symptoms? Or would you advise to have someone screened before planning a family, before planning to have a baby?
If we could find a statistically significant association, it should be considered. But however, it's not a causality. So first of all, we should confirm this causality by RCTs, if the treatment could affect pregnancy outcomes. So for now, it's not recommended actually, but in the future it should be.
Thank you.
I'm sorry. Hello, my name is Nina. I'm from Cardio Intensive Group.
Hello.
And I would like to ask the question, maybe a little bit strange, but I'm not familiar with this topic. So as far as I understand, this mycoplasma, and in general, this is type of the typical microflora for most of the women and without clinical sign. So in your opinion, in your practice, what you would recommend? So we need to do the screening, probably yes, before, as Mikol asked. So what is the titer of the this mycoplasma or this ureoplasma, forever, whatever, after which we should be worried? And do we have any information regarding this that can lead to the increase in risk of the premature birth and so on?
Thank you for your question. It's a very important one because we still do not know about the exact titer. So that's also an aim of our study, to assess the different loads of these bacteria. As we think about colonization, if it's 10 to the fifth, below, more than 10 to the fifth, CFUs per milliliter, so that's the threshold, actually. But it can also depend on other factors, not just the load, so the pathogenicity. It can, as the vaginal flora is quite diverse, it can depend on the inflammation, what it has caused. And it can depend on the different co-infections and also the number of lactobacilli. So we should check the whole flora, and that's also a name of our study, and we would like to assess BV because we have some data about that, if it's linked to BV or not, there is a higher risk or not. So, thank you.
Very complex.
Yeah.
Thank you very much.